So thank you very much. And as I said, we start the first session. There are 6 papers and 6 abstracts that have to be presented. Now, all 6 of them are fairly interesting in their own way. They are some of them are a little more interesting than others. We start with the first abstract. All of them are, of course, this being a breast session, all of them are in the breast, and just gives you a flavor or the current, an insight into the current thinking that happens or that is going on in the ASTRO or in the United States of America. So the very first paper is, of course, looking at a problem that's slightly different. Everybody knows that trastuzumab has added 2 years, especially in small volume disease and in HR positive, HR2 positive, to the extent almost of 37%, where the overall survival is increased, and the 10-year survival has actually increased from almost 78% to 84%. But the problem was that what do you do for 1 to 3 lymph nodes? And does RT really add, or does it bring down the local metastasis, or brings down the local disease? Now, even though the overall survival has increased, the role of RT has been questioned. And this paper is looking at the role. I mean, RT has been always given for more than 4 lymph nodes, but what is the role of RT when it comes to 1 to 3 lymph nodes? Especially where HER2 positive patients are there, and we know when the disease is considered as much more aggressive as compared to HER2 negative. The second paper is again basically looking at the NSAB3 RTOG and GOG combined alliance, wherein they looked at the role of cosmesis, where their whole breast irradiation vis-a-vis partial breast irradiation with RT. Now, there was a small thing that said that if you give partial breast irradiation, especially when you give very high doses of radiation, almost to the letter of almost 385 centigrade, if you gave it conformal, or if you gave it on a BD dose of 340 centigrade, over 5 days, that the cosmesis would be a lot less than giving it as a whole breast as 45 grade. Now, that was seen very similar to the START-A trial, where they looked at the patient, their own assessment, the physician's assessment, and the digital photographs were taken over a period of 36 months. And it was found that actually whether it was, any different or not, because there was an inclination and a thought process, as I said, that if you gave higher dose per fraction, that the cosmesis would be a lot less. The third paper explores looking at phase 1 dose escalation for, again, triple negative. And this is a little more interesting in the sense that, triple negative has always been a bad disease. It's always for younger individuals. It's an aggressive disease. It's a heterogeneous disease, frankly. It's very, very heterogeneous. And it's also associated with hereditary breast cancers, whether you have BRCA1 or 2. And how do you apply these molecular markers, and how do you apply it to TNBC? So there has been, you see, that the options are very little. I mean, now the options are large. I mean, you have taxanes on one end, you have antimetabolites, you have everything else. But there has been a growing interest in active platinum-based compounds. And this is probably a paper that looks at looking at cisplatin concurrent with breast irradiation. Unlike what we do it sequentially or when you do it NACT. But this is looking at a concurrent use of cisplatin along with radiation in TNBC. Now, it is known that TNBC is a lot more sensitive and you end up having a lot more pathological responses, pathological CRs as compared to other variants, subvariants. And it's also known that PCR has played a very large role in the overall survival. It has reflected actually on the overall survival. So the whole idea here in TNBC is to achieve a possibility of getting us. And this paper, looks at that. The fourth paper is looking actually at the HERA trial. The HERA trial is basically otherwise called the Big 101. It's basically a Herceptin adjuvant trial. It's a very large trial. And the question possibly could be that, it was looked at, whether to give trastuzumab, had been proven, or it established the efficacy of trastuzumab. It also established efficacy, whether it was 1 year, was it 2 years. So if you gave only for 1 year, it was more than enough instead of giving for 2 years. But the question here again was whether post-mastectomy RT really brought down the local regional control or local regional recurrences, especially in HR2 positive, which are lymph node positivity. Now, uh, you know, there was, according to the HERA trial, there was a benefit, but it was a lot lesser as compared to what was actually seen in the historical trials. So, in that respect, this paper, the paper number 4, discusses that, and they have explored that possibility. The fifth paper is again a fairly interesting paper in that it looked at the impact of lymphedema. I mean, they have looked at saying they have said that quantifying the impact of regional lymph node irradiation on lymphedema treated by SLBNB or ALND. I mean, if you put it the other way around, it is basically looking at whether the type of surgery really does make a difference when you give post-operative radiotherapy, and does that reflect on the the side effect or the sequelae of radiation, whether it is arm stiffness, whether it's lymphedema, and they have looked at that. The last paper is again, it's a prospective trial. I mean, this is a fairly well-beaten pathway, I think, on the role of hypofractionation in breast. I think in Europe, I think this has already been very well established. I think in India, I think a large number of centers have been doing hypofractionation for a long time. I know PJ has been practicing hypofractionation, I think, for the last 35 years. So frankly, this is something that I think one of the institutes there is looking at in node positivity, whether hypofractionation has a role. I think let's. I mean, we will allow the speaker to discuss it.